Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features expert perspectives from the United States on using immune checkpoint inhibitors to treat patients with advanced urothelial carcinoma. This episode is an installment in a podcast series for clinicians across the world, which is part of a larger educational program titled Application of the Latest Immuno-Oncology Developments to the Treatment of Urothelial Cancer. This podcast features discussion between Dr. Petros Grivas from Seattle Cancer Care Alliance and the University of Washington and Dr. Jonathan Rosenberg of the Memorial Sloan Kettering Cancer Center in New York. For more information on Dr. Grivas and Dr. Rosenberg, along with a link to the complete program, including the other podcast episodes, a downloadable slide set, and on-demand webcast, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
Hello, I'm Petros Grivas. I'm a medical oncologist at Seattle Cancer Care Alliance. I'm an associate professor at the University of Washington and associate member of the Fred Hutchinson Cancer Research Center. I'm very excited and thrilled today to discuss with a dear colleague and friend, Dr. Jonathan Rosenberg from Memorial Sloan Kettering Cancer Center. Jonathan, do you want to introduce yourself?
Yes, I am a medical oncologist at Memorial Sloan Kettering, and I'm the chief of the Genitourinary Oncology Service at Memorial Sloan Kettering. I focus my practice on bladder cancer and urothelial cancer more generally.
Fantastic, Jonathan. And I know you and me are working closely in many different studies. Let me start the conversation here about your comments and impressions from the recent change in the NCCN and European guidelines regarding the management of the frontline setting of advanced urothelial cancer in the context of the results of the JAVELIN Bladder 100 trial that we published recently at the New England Journal of Medicine.
So these results are practice-changing, in my opinion, for most patients. This is a study that took patients who had responses or stable disease to frontline platinum chemotherapy and randomized them to either maintenance of avelumab or best supportive care / observation. And that study showed that there was a significant improvement, an almost 8-month improvement in median survival for patients treated with avelumab compared to observation. And this really is the first time we've seen a dramatic improvement in the outcomes of patients who are receiving first-line therapy in this setting. The one thing to comment is that the patients who had progression on chemotherapy were not included in this trial, and those patients still remain an unmet need, but we do have options for those patients as well.
I totally agree with you, Jonathan, and I believe that the results of the JAVELIN Bladder 100 trial probably give us the best overall survival and overall outcomes data in the frontline setting of advanced urothelial cancer. Obviously, we have not compared this sequential approach to concurrent chemo IO, but it sounds like that the concurrent chemoimmunotherapy trials IMvigor130, KEYNOTE-361 do not appear to confer significant overall survival benefit. And any comments on that about the concurrent versus sequential approach?
You're absolutely right. At this point, the data from IMvigor130, which is testing atezolizumab in combination with chemotherapy, did not show an overall survival advantage in the interim analysis. We'll see what the overall survival final analysis is. And, those trials also included patients who ultimately went on to progress on chemotherapy. And so, a slightly different patient population. They were enrolled at the beginning of first-line therapy rather than after chemotherapy. So it's those two trials themselves didn't improve overall survival. There was a progression-free survival improvement that was seen in IMvigor130 with atezolizumab, although my own impression is that that improvement in progression-free survival was not significant enough to change the standard of care to combination chemoimmunotherapy at this moment. I don't know what your thoughts on that are, Petros.
I totally agree, Jonathan. I think the concurrent chemotherapy plus checkpoint inhibitor approach has not significantly impacted overall survival, and even with a modest progression-free survival benefit seen in the IMvigor130, the hazard ratio was 0.82 with chemo-atezo concurrent combo versus chemo placebo. that modest PFS benefit did not, I think, raise to the level of changing practice. And I think, as you pointed out, we have to wait for the longer follow-up of IMvigor130, as well as the other concurrent chemo trials. For example, the Checkmate 901 is comparing Gemcis-Nivo to Gemcis. There is also the Nile trial with chemotherapy durvalumab, and chemotherapy durvalumab tremelimumab that are ongoing. Of course, the EV302 trial with EV-Pembro versus chemo is also ongoing. But I think until we have a clear and statistical and clinically significant overall survival benefit, I think so far I totally agree with you that my standard approach in the frontline setting is platinum-based chemotherapy, Gemcis or Gemcarbo, depending on platinum fitness, specifically, followed by Swiss maintenance avelumab for those with a response or stable disease.
So, Petros, what do you think about treating patients with single-agent checkpoint inhibitors in the first-line setting?
In this particular setting, Jonathan, my standard practice has been to use Pembro or Atezo in a single-agent approach in patients who cannot tolerate any platinum agent, so cisplatin unfit and carboplatin unfit patients. And there has been an effort that you have been involved, leading that effort along with Dr. Gupta, trying to define this population, the so-called platinum cis and carbo unfit population. And there was a poster that we had at GU ASCO 2019. We have to write the manuscript, but I think this population of patients, it may be those who have poor performance status and impaired kidney function, maybe a combination of ECOG PS2 plus impaired kidney function with low GFR, maybe those with grade 3 neuropathy, patients who are significantly debilitated and frail, and we cannot think we can give them carbo. These are the patients who get definitely checkpoint inhibitor without the need of PD-L1 testing in my practice. Are there any patients who are cisplatin unfit but carbo fit who get Pembro or Atezo? Those patients should have PD-L1 high status based on the FDA label. But this is a very rare scenario in my practice. I have moved towards the sequential approach. Maybe patients who refuse chemotherapy, especially those with lymph node only disease, sometimes I have given checkpoint inhibitor alone. How about you?
So, the FDA labels still stand for those two drugs. And while I agree that it's a much less common usage of first-line checkpoint inhibitor since the avelumab data has come out, there are patients who, based on clinical factors as well as PD-L1 status, meaning PD-L1 high, that I would consider at people who have low-volume disease, nodal disease only, are people who might be cisplatin eligible but platinum eligible. And if their PD-L1 levels are elevated, I would consider giving them an immune checkpoint inhibitor, but obviously that needs to occur in the context of a discussion around the available data and the fact that this is based on phase 2 data. It is interesting that the single-agent arms of the IMvigor130 and KEYNOTE-361 looked quite different, where in IMvigor130, there was at least a numerical improvement in overall survival in PD-L1 high patients receiving immunotherapy as monotherapy, while that did not appear to be the case for patients who received pembrolizumab in KEYNOTE-361. And obviously, there are other differences between the trials, and so those comparisons are a little fraught. But we did clearly see a decrease in survival with immunotherapy in the first 6 to 12 months with single-agent therapy in unselected patients on both trials. And in IMvigor130, when you pull out the PD-L1 high patients, there is a trend, although it is not statistically significant at this point, for overall survival in that population, whereas in KEYNOTE-361, that did not appear to be the case, which is very interesting. Which leads us to the biomarker discussion, actually, Petros. What is your opinion of PD-L1 testing and how we can use it in its performance in different contexts?
This is a great question, Jonathan. And just to add your point and answer your question, if we look carefully at the 3 frontline trials that were recently presented, IMvigor130, KEYNOTE-361, and the Danube trial, in all of those trials, if you look specifically at the combination of treatment versus chemotherapy, there is no significantly benefit compared to chemotherapy. Now you focus your attention to the checkpoint inhibitor alone approach, for example, durvalumab versus chemotherapy in the PD-L1 high patients in the Danube trial, or the pembro alone versus chemotherapy in the KEYNOTE-361, as well as the atezo alone in PD-L1 high patients compared to chemo alone. In neither of those three trials, there is any clear overall survival benefit with checkpoint inhibitor compared to chemotherapy, even in the subset of patients with PD-L1 high expression, which I think raises the question whether we have a clear role to continue checking PD-L1 in this setting. As you mentioned before, the FDA label still stands, but I think in the context of these three trials, and also in the context of JAVELIN, I think the checkpoint inhibitor alone approach becomes less used. I think there is also the point about the variable PD-L1 assays, and I think you have made the point before in different talks and lectures that we cannot mix and match. PD-L1 assays are different, and if you use, for example, the DACO-22C3 assay with a CPS score, this in the context of use of pembrolizumab, the Ventanes P142 assays in the context of use of atezolizumab, and I think we cannot, mix and match different assays. In my opinion, the totality of the data, even the PD-L1 high, just have difficulty showing superiority of checkpoint inhibitor. And that you mentioned, in PD-L1 low patients, definitely chemotherapy appears to have less deaths in the first year, although after a year, the two curves, checkpoint inhibitor alone and chemotherapy, come together in the PD-L1 low patients. So all of the above make me wonder whether the utilization of PD-L1 as a biomarker becomes less and less relevant in the frontline setting. Only in very few patients, as you mentioned, who probably refuse chemotherapy, and you may have the option of giving pembro or atezo if they're carbo fit and they're cystatin unfit.
Yeah, I guess I would generally agree that PD-L1 is relatively difficult to use as a biomarker, and every time we think we understand where it's going to work, it doesn't quite work the same way. I would say that although this difference in the single agent PD-L1 high arm of IMvigor130 did not it was an interim analysis, the curves are quite far apart from each other. And there's many potential confounding factors in how that trial was conducted that perhaps could account for it. But I do think that the jury is still out for that drug in that trial at the moment. But I agree. I think it's the use of PD-L1 inhibitors in the first line setting there's a shrinking role for it in people who are eligible to get platinum chemotherapy. What is your thought around post-platinum, post-checkpoint patients? So people who get avelumab maintenance after chemotherapy, what is your go-to drug? And people who progress on first-line chemotherapy, who aren't eligible for maintenance, what is your go-to?
Absolutely. And just a very quick comment on your previous observation. I agree with you that we still have to look at the longer follow-up of IMvigor130, both the chemo-atezo combination for the overall survival and also this interesting survival curves of atezo alone versus chemo alone in the PD-L1 high patients. The hazard ratio was 0.68. It was not significant, but definitely was raised some interest for follow-up. And the other quick point I would make is that we published recently data with pembrolizumab alone from the KEYNOTE-52 trial in patients who are more senior in age and have poor performance status, equal PS2, about 42% of those patients in the KEYNOTE-52 trial. And those patients appear to benefit from pembro similarly to younger and fitter patients. So definitely there is a role for checkpoint inhibitors, especially again for patients who may not be able to tolerate any platinum agents. But for those patients, to your point, who progress on platinum-based chemotherapy and they cannot get into switch maintenance avelumab, I think at this point, based on the currently available evidence, the options include pembrolizumab based on the KEYNOTE-045 trial published at the New Journal of Medicine 3 years ago, pembrolizumab versus salvage chemotherapy, taxane single agent versus viflunine, or viflunine in Europe, either or, and pembrolizumab prolonged overall survival versus taxane or viflunine, and the hazard ratio was, I think, compelling. And based on this data, I think pembrolizumab is probably the only checkpoint inhibitor in the platinum refractory setting that has achieved level 1 evidence based on this trial. There's a lot of discussion about atezolizumab and the IMvigor211 trial that actually did not meet the primary endpoint of overall survival in the PD-L1 high patients. That was the primary endpoint. However, it met the overall survival in all comers with a modest benefit. Even if I think personally that the biomarker-based design was probably responsible for the results of the IMvigor211, I think we have to follow the level of evidence, and the checkpoint inhibitor of choice in the platinum refractory setting, in my opinion, practice is pembrolizumab based on the KEYNOTE-45 trial. And the other 3 checkpoint inhibitors, nivolumab, avelumab, are FDA approved, but have evidence based on phase 2 trials, so lower level of evidence. The other option there will be erdafitinib, an FGF receptor inhibitor approved for platinum refractory disease based on the phase 2 single agent BLC 2001 trial, based on durable response and manageable toxicity and promising efficacy of erdafitinib, but only in patients with FGFR2 or FGFR3 mutation or fusion. And the third trial, phase 3 trial, is comparing actively, prospectively, erdafitinib to pembrolizumab in those mutated or fused FGFR2 tumors. And I think this will give us the answer in the second line. So either pembro or erdafitinib, and I would say clinical trial is definitely an option always in the first or second or subsequent lines. And enfortumab vedotin, based on the label, is usually after immunotherapy. What is your practice, Jonathan, based on the above?
Yeah, so I would actually agree completely. I mean, while erdafitinib is an option after platinum chemotherapy, I would say I would employ a checkpoint inhibitor, regardless of FGFR3 status in that patient population. I think the data is relatively murky at the moment around the benefit of a checkpoint inhibitor in an FGFR3 mutant patient, similar to the murkiness of the data around PD-L1 testing. And so I often use erdafitinib as a third or fourth line agent, whereas enfortumab is generally used in the third line setting outside of a clinical trial following progression on platinum chemotherapy and immunotherapy. And in that context, it has a lot of activity, and there's been, as you know, a press release indicating that EV301, which is the third line confirmatory trial, was positive, again comparing to taxane or vinflunine with an improved overall survival with a hazard ratio of about 0.7. So we look forward to seeing that data, but we don't have that data available at this point to discuss in any depth.
Jonathan, let me ask you the question. If you have a patient who has progression on platinum-based chemotherapy, primary progression, cannot get avelumab switch maintenance because of the progression, and this patient has an active autoimmune disease, let's say has lupus erythematosus, actively on steroids, had a flare a month ago, and you're worried about giving checkpoint inhibitor. And this patient, let's say two scenarios. If this patient has an FGF receptor 2 or 3 mutation or fusion, or if the patient does not have this mutation or fusion, what would be your approach in the absence of a clinical trial in this?
Yeah, I think if there's really compelling contraindications for an immune checkpoint inhibitor, which includes the more severe autoimmune diseases, then if there is an alternative approach, that would be preferred with a drug like erdafitinib. You could also consider using enfortumab vedotin. There are potential reimbursement issues in the United States with using enfortumab in the second line setting as opposed to the third line setting. But in general, if there's a contraindication to immunotherapy, it shouldn't be a huge barrier. Obviously, clinical trials, non-immunotherapy clinical trials might be a great option for that patient as well, to think about in a setting of a person who has a real contraindication. I think, most of the skin disorders that are autoimmune in nature, unless they're really severe, are things that would not necessarily keep me from treating patients. And many of the sort of rheumatologic, but not many of the rheumatologic diseases like rheumatoid arthritis, et cetera, wouldn't necessarily be contraindications to use immunotherapy, although it's my experience that they often flare and require additional treatment.
And actually that raises the question, Jonathan, regarding the management of the immune-related adverse events that can happen with any checkpoint inhibitor, and it's probably more common with combinations of checkpoint inhibitors as we're seeing in clinical trials and other tumor types. Let me ask you, what is your go-to guideline, if any, at your practice in terms of education, recognition, and management of immunotherapy-related adverse events?
We generally tell patients to let us know about anything that might be we would consider more serious, like diarrhea that is persistent, shortness of breath or cough, both representing colitis or pneumonitis, dramatic changes in energy levels or skin rashes. We monitor patients with LFTs prior to each infusion, looking for hepatotoxicity, and certainly have and also evaluate thyroid function periodically, because many patients end up with thyroiditis and hypothyroidism. And so, seeing patients, at least initially, on a very regular basis, coinciding with their treatments, is, I think, important. In the pandemic, this is obviously more difficult, but as time goes on, hopefully, we'll be able to have more in-person contact with our patients.
I agree with you, and I think the pandemic represents many challenges in multiple ways across in trials and also monitoring of patients. And when I may switch a patient from every 3 weeks to every 6 weeks pembrolizumab that now has FDA approval, if the patient is doing well and has no toxicity, I'm still worried sometimes, if I miss any side effect in the interim, and patients tend to underreport sometimes, right, adverse events because they want to stay on therapy. Have you had the same kind of observation?
Yes, and that's a much harder thing to detect either over the phone or a video call when you can't actually see them move, and it interferes with your ability to understand performance status in that scenario. But which is why often people do just need to come in, and we and other folks are taking obviously quite rigorous steps to keep people safe. But at the end of the day, telemedicine is going to be with us in the treatment of cancer, and we just have to ensure patient safety and use it appropriately.
Totally agree. And before we close, Jonathan, let me pick your brain that can comment on it. What are the most exciting clinical trials right now, especially with immunotherapy in any line in advanced urothelial cancer, in your opinion?
There are some interesting trials looking at IL-2 pathway stimulants in first and second line therapy. There are some very interesting trials looking at ICOS agonism, trials looking at the aryl hydrocarbon receptor, which is involved in immune response. There are a lot of really exciting novel agents that are being tested either as single agents or in combination with immune checkpoint inhibitors. And these are often and things like LAG3 that are other immune checkpoints that might be involved in resistance. I think one of the most important things we can do on these trials is to try to understand factors that might predispose patients to have a response or to be resistant, so that we might actually come to a point where we can select patients with more sophisticated biomarkers for those who might be prone to resistance to single-agent checkpoint therapy.
Absolutely, and I know you have done plenty and you continue to do plenty of research in terms of the biomarkers, and I'm personally very interested, as you mentioned, in other checkpoint inhibitors. I'm interested in TGF-beta inhibition, and there are molecules inhibiting PD-L1 and TGF-beta, and also anti-angiogenesis. And you have led a large trial with CLGB 90601 with gemcitabine bevacizumab versus gemcitabine. It did not prolong overall survival. You saw the data at ASCO in 2019. But do you think that maybe anti-angiogenesis may have a better luck combined with immunotherapy?
I think that there's a new life for those agents in urothelial cancer. I agree, and there's trials coming up testing drugs like cabozantinib. It's interesting, though, that it's not just angiogenesis that's probably being affected. There are a lot of other kinases, particularly those on macrophages and lymphocytes, that are probably being affected by these multi-targeted so-called dirty kinases. And we've seen activity of sitravatinib, we've seen activity of cabozantinib, both in combination with immunotherapy. And there'll be, we hope there'll be larger phase 3 trials coming forward with those agents. As with any type TKI, for people who treat a lot of kidney cancer as well, you recognize that there's toxicity associated with these drugs, and they do add to the toxicity profile of the immunotherapy.
I totally agree, Jonathan. Any last comment where you think the field is going in urothelial cancer? Do you think personalized therapy can be a reality, or we're far away from it?
I think personalized therapy on a clinical basis is already a reality. I think we think about each patient individually, but as from a biomarker perspective, I still think we're not as close as we'd like for all lines of therapy. Next generation sequencing has shown us that FGFR3 is a target, and we can personalize therapy based on that. But I'm very optimistic about the field in general. We've seen substantial, dramatic, and historically unheard of improvements in the treatment options available for patients with advanced urothelial cancer that we only dreamed about 10 years ago. And so I'm very happy to have been involved in this, and it really is a very exciting time to be an oncologist because we really are helping our patients live longer and live better, which is the goal. And eventually, hopefully, we'll see things that are actually curing patients on a reliable basis.
I could not agree more. And as you said, if you think about even 5 years ago, there was not the presence of all these new agents, checkpoint inhibitors, erdafitinib and enfortumab, and many approvals that happened in the last few years. I agree with you. Personalized medicine is a concept that applies in the clinical practice now. We individualize based on clinical factors, medical comorbidities, performance status, genomic characteristics, sometimes FGFR3 mutations is an example. And I think in the future, to your point, with exciting ongoing clinical trials, utilizing not only immunotherapy, but also targeted therapies in a better selection mode, if we select the patients better on biomarkers, we may also have better luck with precision oncology, which is something that lags behind in urothelial cancer. But I agree totally with you. It's extremely exciting to be an oncologist, specifically focusing on urothelial cancer. And we're thrilled to try to work as a team to move the field forward. And I appreciate all you do in the field. And thank you for your time today, Jonathan.
Thank you, Petros, and it's been a pleasure, as always.
Thank you very much, Dr. Grivas and Dr. Rosenberg, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, application of the latest immuno-oncology developments to the treatment of urothelial cancer, please click on the link in the show notes. As always, thanks for listening.